And again, Mariano, thank you for the introduction. And I know we might be running a little late now because of this. So if you want me to cut shorter, I will. I am available. I don't have anything else tonight. So these are my disclosures. Just a little bit particular for the young fellows, you know, hopefully this serves as an inspiration. But as you know, I grew up very close to you guys. And whenever the dollar to real was good, we would actually be visiting you guys, and vice versa, I'm sure. So that's how I grew up as a teenager, and did my medical school at the Federal University in Rio Grande do Sul, and I graduated in 1995. But a pivotal moment, I would say, on my academic life as a junior general surgery resident was when I rotated on Dr. Adamastor Pereira, who is friends of many of ours. And at that point, he was doing the first endovascular aortic repair in Porto Alegre. And Dr. René Uflacker, who was his classmate on the same medical school that I was doing, is now passed away years ago. Many of you have known Dr. Uflacker. He was a very prominent interventional radiologist, and he came to Porto Alegre to assist and teach Dr. Pereira, and I was really, really impressed with this new technique. And at that point, that was one of the stimulating factors for me to come to the United States. So in 1998, I went to initially Utah and then to Rochester, Minnesota, where I completed my training. Right there on that year that I went to the US, the first fenestrated repair was performed in Australia by John Anderson. This was not the first fenestrated repair in the world. The first one was 1996 by an interventional radiology in South Korea. And a few years later, then Tim Schutter introduced the concept of using branches. And these illustrations you're seeing are actually exact replicas of the first stent that were used. Now, one of the biggest honors I had on my career was right when I was finishing from the first to the second year of fellowship at the Mayo Clinic, that this gentleman approached me and invited me to join the staff of the Mayo Clinic. And at that point, they already had an extensive experience with open surgery of all types, in particular aortic surgery. And Mayo was a powerhouse for open surgery. So I was really well trained in open surgery, actually, to begin with. But I remember I said, Dr. Glowicki, I'm very honored with this invitation to join the Mayo Clinic staff. But just be aware that we're going to be treating thoracoabdominal aneurysms with stents. And this was the answer I got from them, the response. So they couldn't believe it. Fast forward another year, now I was already staff at Mayo, and I went to the Cleveland Clinic as a scholar, as a Mayo Clinic scholar, to work with Roy Greenberg for a short period of time. But at that stage of the career, even a short period of time made a tremendous impression. And when I returned, Dr. Glowicki was waiting for me with a patient that had a symptomatic complex abdominal aneurysm, a previous pancreatectomy for necrotizing pancreatitis and hernia repair. And he asked me to fix this with a fenestrated graft, and I told Dr. Glowicki, we don't really have a fenestrated graft. We're probably not going to have it in the United States for many years. He said, I don't care really, Gustavo. You figure out how to do this. So I went to the literature, and I went back to Dr. Uflacker now with Claudio Schoenhaus, friends of us, and the CACI Evensef. They had done this report about how to modify a Xena device. And right off the bat, our first case was a 4-vessel fenestrated repair on this patient. And throughout the next years, and that's when I got to meet Mariano, really we didn't have access to manufacture devices. So we became, quite good about making the devices ourselves with fenestrations, branches, wires, preloaded wires, etc. And to this date, I think this is a very useful technique, actually. But through the process of this, we started to be invited for clinical trials. And in fact, by the time I left Mayo, we already had been participating in over 25 device trials. And one of these was a prospective, what we call PSIDE, physician-sponsor IDE, which is basically the mechanism that the FDA allows physicians like myself to get access to technology that is not yet commercially approved. So fast forward, again, 16 years from the start of the program, with a lot more experience. Where we are at now, well, last year I had the chance to help writing this very extensive document for the American Heart Association. And that is like the need-to-know document on aortic disease, from the aortic valve to the iliac arteries. Now, as with any document that is very extensive, you lose a little bit of the detail, but nonetheless, it did make some recommendations about thoracoabdominal aneurysms. And one thing that is very clear is that both open surgery and endovascular surgery have a critical role in the management of these patients. And they shouldn't be seen as competitive classes, but complementary classes in the management of thoracoabdominal aneurysms. So that, for example, for connective tissue disorder, open surgery remains still as the gold standard with a class 1 recommendation. The size criteria in most centers is 6 centimeters, but fenestrated branch endovascular repair should be considered when available, if the anatomy allows, in centers that have expertise and access to these devices. Still, you'll find papers on the literature that generalize open repair as the gold standard, which I disagree, and I'll show you why. But why do we find papers like this? Why are we still struggling to say that endovascular therapy can be superior or may be superior in many settings? Well, there are many explanations, but mostly we have relied over the years in single center experiences, which are relatively small size, follow-up being short, reinterventions are high. The fact is these devices are not widely available, and we still wait for insurance approval and manufacturing. And also the fact is this is very expensive technology. So those are the critics to endovascular. But what is the bar that we have to surpass to say at some point endovascular is now the gold standard? Well, when we look at mortality, this was a landmark experience in the tail end of the career of Dr. Crawford. And his mortality was 10% for over 1,500 cases, which was a remarkable feat. Now, fast forward exactly 3 decades, we actually didn't get a lot better in terms of mortality. Look at this large series from the 1990s, 2000s, 2010, where the mortality hover around 10% in most centers. In fact, this is a systematic review which only included the top centers. And you can see the mortality for extent 2 thoracos is about 10%, ranges between 7 to 13% in the best series. And even for extent 4, which we would think, gee, this is the easiest of all thoracos. In fact, it's not the case, because we know that patients with extent thoracos are older and they have more atherosclerosis than patients that have extent 2 thoracos. So from one end, you would think it's easier, but from the other end, managing these patients is actually, with open surgery, sometimes more difficult. And that's the other problem. In fact, only 1/3 of the patients are treated by the Cosellis and Safis and Estreras, and actually 2/3 don't actually come to large volume centers. So we need a technique that is more, let's say, applicable and disseminated than open surgery. Open surgery is extremely valuable, but the fact of the matter is that it can only be done very well in a few centers. The other aspect is we are not only worried about mortality, are we? We were worried about many other things. In fact, when we look at the rate of complications of open surgery, there is a high rate of respiratory failure, a high rate of dialysis, and spinal injury. The one area, however, that has greatly improved from Dr. Crawford's experience with clamp and go to the current era with distal organ protection is paraplegia. At the time Dr. Crawford was doing this in the 1980s, 1 out of 3 patients of extent 2 thorax would become paraplegic. Nowadays, that's 4 to 5%, and that's actually not an easy number to beat. Now, the other area that open surgery proponents argue is that, well, gee, this is the most durable alternative. Well, if you define durability as aortic reoperation, that might be the case, because in fact it's very durable. But I want to say aortic reoperation is not how we measure durability for endovascular procedures. We measure based on secondary interventions. And secondary interventions is not the same. It should include any secondary procedure that you do after an index operation, which means that you have to factor things that happen early on after an open surgery, such as going back to the operating room for bleeding, or an early reintervention, or also problems that are not directly related to the aorta, but to the target vessels or to laparotomy problems. And these problems are not trivial. In fact, sometimes they can be deadly. So Ying Huang, who is now here on our staff, has reviewed a very matched cohort at Mayo, and this is something we are submitting this year for a very high impact journal. But we compared open and endo using the same type of definitions. And we saw that the endo program has been very valuable to decrease the age of open surgery patients by 2 decades over the last 10 years. But when we look at secondary interventions, the non-aortic reinterventions happen much more commonly with open surgery, which is not surprising. And the endovascular the aortic reinterventions, they happen more frequently with endovascular, but even with the aortic cases, they do happen. And when we look at overall, which is the sum of both, actually endovascular is slightly superior than open in 3 years. Actually, there is a less of a chance of a patient going back to the OR with endovascular as compared to open. And in fact, many of these problems are of less magnitude and less physiologic stress to the patient. So, not so early. Now, coming back to the IDE, what's important for you to know, and Mariano knows this because he visited me at Mayo, is that this is indeed a prospective study. The data is collected on time. It's actually adjudicated by a clinical event committee and is filtered by a data safety monitoring board and is reported every year to the FDA. So this does represent the highest level of integrity in research and evidence for fenestrated repair. And it's a lot of work. This document of 2 volumes is actually the IDE document, which had to be written, submitted to the FDA to Medicare for reimbursement. Every case has to be sized, and I'm heavily involved on every sizing. Then we collect the data prospectively in questionnaires, and we enter into a computer database, and then we report this to the FDA every year. And we have to do it year after year after year after year. And now we have to do it for Mayo and for UT. So here is the results of the first 430 patients on this IDE. And the overall 30-day mortality was 1%. So we lost 4 patients out of the 430. And the patient survival at 5 years was just short of 60%. And the freedom from aortic-related mortality was excellent, was 98% all the way through 5 years. And this IDE has led to a number of landmark publications and great work by the research fellows that worked with me. Many of you know personally, and this has been really one of the most rewarding aspects of my career. But one of the things I was worried is, can I actually reproduce these results in Houston? You know, historically, the mortality here in Houston was 15% for thoracic. So can we reproduce these results here in Houston? So that was the topic of a recent study we did. And you can see the referral distribution from Mayo to Houston and see that actually a large number of patients I see are outside of Houston. They are coming from other states. And the numbers are already picking up. Last year, which was my second year here in Houston, we did 65 thoracoabdominal aneurysms. And we are heading this year probably somewhere between 70 to 80. But let me tell you the results of this in the first 573 consecutive cases. So we've noticed that here in Houston, the patients are sicker. They have a high rate of ASA classification greater than 3. They have more previous repairs, more genetic disease, more ruptures, larger aneurysms, far more thoracals, more dissections. And something I change in my practice. Less often they have drains, and less often I use upper extremity access. To illustrate, let me show you one of the cases I treated here in Houston. And you cannot make this up. You can see on this X-ray there is something missing here, and that's both of the patient's legs, because he had a type A dissection 10 years ago. He was quite late into the diagnosis, and he ended up having bilateral hip disarticulation. So you know that a consequence of that is that his iliac artery is occluded in one side and is very small in the other side. So we don't have really access. Also note on the illustration here by David Factor that the true lumen is very much squished, very squished, and with a huge false lumen. So this is the CT angiography. You can see the arch and thoracoabdominal aortic aneurysm, and note the true lumen is extremely squished and the flow via the true and false lumen. So this is a summary here. You see the true lumen is about 12 millimeters in the chest, which usually is not a major issue. It can be an issue, but I'll show you a technique that I think that has been great over the last year. We used in a number of times, including this week. So this is the plan. He has a colostomy in the middle of the abdomen. I plan to do this in 2 stages. The first stage, we requested a 3-vessel arch device. I did a conduit, which was quite difficult because he had atrophy of the psoas muscle. He had a previous colectomy, so everything was distorted and scarred. And this was the plan. I did this on a hybrid room, totally percutaneously on the axillary puncture and with a conduit on the left. And this is like a short segment of the case. You can see that I went on purpose to the false lumen. We confirmed that with IVUS. We then use only fusion to calibrate the anatomy. You can see the device advanced across the aortic valve, and with rapid ventricular pacing is deployed so that the inner branches are facing the vessels. Now working from the right axillary puncture, we extended the repair to the innominate artery, and we restore flow there. And using this steerable sheath from the groin, we proceeded with the left carotid artery stenting first, and then finally, after this was done, we proceeded with the subclavian stent. We had another curveball that the vertebral artery was coming from a very squished through lumen, so I had to document collateralization before we actually excluded that vertebral, but not surprisingly, the patient had good collateral. Now, this is the issue now. Remember, we are in the false lumen, so I'm going to connect the true and the false lumen, and that's done with a thermal septotomy. So I orient the snare and the guide, and after I connect this wire to the cautery, at the cut mode, This goes, I like to say, like a lightsaber. You know, it's just very, very efficient and safe. And now we are scraping the coating of the wire, and we protect both ends with catheters. And now you can see I'm not doing any force to cut that septum. And we now connect it through and false looming. And fast forward to the second stage. The other thing that I did is I buried the conduit in the soft tissue, and I waited 2 weeks. I didn't want to wait too long. Then thrombectomized that conduit and proceeded with the second stage using a preloaded device. And this device has 2 catheters loaded through the delivery system, which allows you to do those renal arteries concurrent with the deployment of the device. And you can see I'm working now with the preload on the left kidney, and that's with the preload sheath. And after we secure access, position our ICAST stand, we then repeat the same step on the right side. And we deploy the stands, flare it, the standard thing we fenestrated. And after this, now we're going to use the steerable sheath with a locking wire. And you can see now we're working in the SMA from the total femoral approach and completing the repair into the SMA. And finally, we move upwards towards the celiac axis and do the same step to complete to the celiac axis. So this patient did well, did not have any major complication, and it continues to do okay. Now, this is the mortality rate, so it's really not statistically significantly different, and it's still hovering in a low range of around 1%, with similar outcomes despite the patients being in a new system and also more high risk. The patient survival is similar in both groups. Interestingly, overall survival is slightly higher than the ARC. And the other thing I wanted to see is how it compares with Dr. Coselli's survival, which is actually similar. But remember, the series, the open series, is start at about 10 years older age than the endovascular series. Survival is less for the extent 1 to 3 thorax compared to the complex abdominal aneurysms. The other question, is the technique effective? Are we doing any favor to our patients? And the answer is yes. Ultimately, what we're trying to prevent is aortic death, and aortic death is a death from a rupture or from the treatment of the aneurysm, and that rate is 2.3% up to 5 years with low rate of rupture. So the patients are dying, but they are not dying from aortic disease, they're dying from something else, which means we have to actually do quite a bit of work in medical therapy of these patients to improve that. But you know, this study might be very good from the standpoint of scientific rigor, evidence in terms of adjudication, but it's a single surgeon center experience, so it's not generalizable. And if we look at the quality initiatives, which are the VQIs and so forth, their problem is that you don't have any granularity and you don't have any homogeneity on techniques or devices. And actually, you don't have very good follow-up. So that doesn't help. So the first initiative we had, which was the United States Fenestrated Branch Aortic Consortium, was myself and Emmanuel Tenorio in 2018, pulling together the data of these sites to look at chronic dissections. That was the first paper of what's called today the US ARC. But as Henry Ford said, coming together is a beginning, staying together is progress, and working together is success. So we were able to actually come a long way together, and we secured funding. We have now a digital database that is prospective and entered on time. We continue to have adjudication. We have data sharing agreements. And this really became a pipeline of very important projects on this field. And I'll share with you progressively a lot of the projects and a lot of the lessons we learned about fenestrate repair. On this initial paper by Carlos Timaran, we learned that preloaded wires and catheters were associated with better technical success, decreased operative time and radiation, but were not with lower mortality. We then went on to increase the series, and Edmund et al. From Andy Schanzer's group look at the effect of sex and learned that women experience higher rates of technical failure, actually, had more extensive aneurysms. More frequently, they required to be dismissed to nursing home or rehabs, and they actually had higher rates of sac expansion compared to men. Now, that suggests that there may be some design improvements that needed to offset this disparity. The series continued to increase, and now this paper by Mark Farber with Fernando Mota shows that actually in octogenarians, on this group, fenestrine repair was very safe, very effective, that the mortality was low, no different, and the freedom from target instability was also similar. Andy Schanzer again look at the use of fenestrine repair after failed EVAR, and also showed this is safe, also effective with patients with previous EVAR, nearly identical outcomes. It is a more difficult procedure, however, and we recently published, basically last month, that patients with failed EVAR continue to have sac growth at a rate that is much, much higher than patients that never had a previous EVAR. So this is a problem and is likely an inflammatory problem. Now, Sarah, working with Matt Sweet at the University of Washington in Seattle, looked at the impact of secondary interventions, which is very important. You can see the vast majority of secondary interventions are minor, low impact. And in fact, they don't affect survival. We then had Carlos Timaran again look at transfemoral versus brachial axis. And this is a paper that influenced everybody. And that's why we are all trying to move away from upper arm axis, which is actually not terrible, and it's very important, and I used for a decade. But if you can avoid it, you save yourself a 2 to 3% stroke rate, and that's what Carlos showed, and we recently reproduced in our series. Emmanuel, who has been incredibly productive, looked at the series with over 6,600 target vessels, and this is the definitive paper on this. And you can see directional branches, although we love them because they allow us to have off-the-shelf devices. Unequivocally, they have lower patency rates, lower freedom from target instability, and in fact, for the renal arteries, the patency was 83% at 5 years, and is about 10% higher with fenestrations at 5 years, even when we adjust for the type of aneurysm. Emmanuel again look at the type of bridging stent for directional branches, and balloon expandable stent grafts have lower freedom from target instability, mostly because of a higher rate of endoleak. And even though this has been shown before, it has been criticized or controversial, this paper now has 2,400 directional branches. The other thing that we learned is that if you are going to use a stent, don't use an ICAS stent. Pretty much all the other stents had similar behavior for branches, but the ICAS stent is the one that had the worst outcome for branches. And finally, Victoria from Adam Beck's group looked at paraplegia rates, and the rate was 7%, 5 times higher for extent 1 to 3 thoracal. So think about that when you have a pararenal aneurysm to be treated with a T-branch. The rate of paraplegia is 5 times higher than if you were to do a shorter repair. Now, the one thing that is news on this paper is the survival for paraparesis was identical to those that had no injury, which is news because we always felt that they did poorly, but no, reversible deficits and paraparesis, they do much better than paraplegia. Coming back to the recent VAM, which was last week, Eric Finesgaard published on acute kidney injury, which happens in 1 out of 5 patients with fenestrine repair, more frequently in those with pre-existing injury, technical issues, and longer operations. And the severity of the injury affects early mortality, but also late mortality. Now, the US ARC now has over almost 4,000 patients. This is actually outdated. Over 10,000 targets, and you can see the enrollment in the 10 sites. And the overall mortality for this is actually quite low. It's 2.3%. And even for extent 1 to 3 thorax, it's 2.8%. So that is a very low bar to beat with open surgery. And you can see that across the board, with exception of one center, the mortalities hover between 1 to 3% for thoracoabdominal aneurysms. This is again shown to be effective. So the risk of aortic-related mortality is low at 5 years, 5%. That includes the early mortality. We meet regularly every month. We have new projects that are approved. This is a list of projects. Again, this has been a major advance. We also try to create an international multi-center aortic research group. And if you are all interested, we would love to have either as one site or a combination of several sites from Argentina, data from South America as well. And this allows to have more flexibility in terms of what's being done across the oceans. And also some have access to devices we don't have, like the false lumen occlusion devices in Europe, the inner branches, etc. So it's very important. You can see here on the multi-center group the enrollment of patients in different sites. Of course, I'll talk to you a little bit more about paraplegia because that is the bane of our existence. And you can see the rates are all over the place, 0 to 29%. And one of the reasons for that is because people include on their studies high and low risk groups, and they mix them together. And not all the centers are the same. Some are early in the learning curve, some are late, some have high volume, low volume. There is inconsistency on how you define, and there is lack of prospective studies on this. So, but you can see that coverage, the extent of coverage is the most important. And I like this rule of 1, 5, and 10% for extent 4, 3, and 1 to 2. That's usually what I tell my patients. Now, we started with a belt and suspenders approach. So this is what I used to do. Staged repair, neuromonitoring, routine drainage, permissive hypertension, limb reperfusion, temporary aneurysm sac perfusion in those that had changes in neuromonitoring. And again, these are the numbers we got using this protocol. 8% spinal injury, remember that number, 4% paraplegia. But we had disappointments. One of them is 1 out of 5 injuries in the spine were due to a hematoma, like this patient. And that's when I started to have issues with spinal drain. And one of the reasons we had more hematomas is because we actually checked every patient that had injury with an MRI. So we could diagnose hematomas. It's amazing. If you don't do an MRI, you don't have any hematomas in the spine. It's just amazing because very rarely the blood is going to pour out through the puncture hole of the needle. So it stays inside. Now, hematomas were not the only problem. We also had bleeding in the head. And in fact, we're not the only sites to have that. So as of 3-4 years ago, we abandoned using prophylactic drainage. And this is now a series from Juliana Marcondes with 41 patients with extent 1 to 3 thorax without any drain whatsoever. This is no prophylactic drainage. What did she find out? Well, the rates were identical to what we experienced. So the overall rate was 8% and 4%. And most importantly, we worried what happens if you have an injury without a drain? Well, 73% of them improved with rescue maneuvers. And none of the patients in this series of the 540 experienced a spine hematoma. So that is a very compelling reason for you not to use a drain. But the caveat here is you have to have a rescue team to be able to put a drain if needed. And again, going back to Vitoria's paper, if they have an injury and you reverse them, the survival is the same as if they don't have an injury. So how is the ARC doing with respect to drain? Well, most sites don't use a drain prophylactically, only therapeutic. 3 sites use prophylactic drains, and 2 sites are randomizing patients to a trial. We also looked at chronic dissections, which when I started doing fenestrated repair was a taboo. I mean, like, this is the toughest case. Don't go there. The stent is going to collapse. You can't catheterize the vessels. Well, we learned that this is not the case. In fact, it's usually easier to catheterize the vessels. And if you do a stagger technique, it's actually quite safe. The stents actually usually expand. And now with the septotomy technique, we can even cut the septum and do a branch endograft in many cases. So this is a series of 246 patients. And you can see that the results are very respectful, with a mortality of 3% and rate of injury that's similar to what we observed in the ARC. The patient survival was 65% at 5 years, but the freedom from aortic death was 93% at 5 years. And again, the issue is reinterventions. And I want to acknowledge that. I think with chronic dissections, we have more reinterventions than degenerative aneurysms. So we have endoleaks, more endoleaks, and we have more target-related problems. So we have to be careful with that. Now, Marina from Porto worked with me for a year and did this recent paper on the effect of staging. And staging is something we borrowed from Randy Grip, who just passed away last year. And the theory that by promoting these collateral networks, we can decrease the rate of spinal injury. That can be done a variety of ways: temporary sac perfusion. In Europe, they do the minimally invasive coil embolization, the Misachi. And we do what Roy Greenberg championed, which is to do a TVAR first and then complete the repair later with a branched endograft. And this is a series now of 1,600 patients, where we noted that the mortality was nearly half with staged, and the rate of permanent paraplegia was less, as well as the composite of both. Now, one criticism to this is that you do lose some patients from ruptures between the 2 stages. And we've noted on a recent series from Mayo, usually those are patients with aneurysms of larger than 7 millimeters. So in fact, I'm kind of in the process of shifting and more trying to do single stage procedures in the patients that have exceptionally large aneurysms. But you have to be careful with that. It's a trade-off. And I think that you get a little higher mortality with that. Let me fast forward to the future. Now, Ken Tran is a resident now staff at Stanford. And we collaborated with them because they have an outstanding lab of computational fluid analysis. They didn't quite have the patients and the anatomy, which we provided from the IDE, but I wanted to do this study, a case control study, where we would see if we could identify, using computational fluid analysis, which patients are going to occlude the branches. So we sent 10 cases of directional renal branches that occluded, and controls that were matched for angulation, size of renal artery, etc. And we noted that actually on the CT before the branch occluded, that branch that occluded had significantly lower flow and higher resistance, which could have been identified ahead of time. This is an example of one of such branch. You can see in red, well above physiologic range for wall shear stress. And you can see here the comparison of a branch that occluded on the right with a branch that didn't occlude on the left. That the question here is, can we have in the future some software where we plot this as we see these patients on follow-up, and based on that we can change medical therapy? Or even beyond that, can we plot this preoperatively with a phantom model of the stent we intend to use, and find out which design actually has lower shear stress? and we select that design. I don't know, maybe we can. The other issue we are very worried is radiation, and we are mostly worried if we're doing complex cases, because actually they have 15 times higher radiation dose. And this is a big deal. You know, we learned that even a single case, if you check your DNA, it already has DNA damage. Just from a single case, you draw your blood, you check the lymphocytes, and they already change. And if you do this for years, you have actually chromosomal aberrations. And unfortunately, I was one of the operators on this study that donated blood for this study that found chromosomal aberrations from radiation. So that is a huge deal. And there is so much you can get better. This is my radiation fluoroscopy time dose, actually, over the years. And you can see that I didn't really get much better since 2012. So it's about the same. So we're looking at alternatives to radiation. One of them, you know the force from Philips, but we have also the IOPS, which is agnostic to any imaging. And I'll show you a couple of experiments we did. One of them is we sensorize a device, and we took this to a 3D model in the OR, and the goal here was to do an EVAR without any radiation whatsoever, and any fluoroscopy whatsoever. So we did that by suturing, because they don't have wireless sensors yet, but imagine if they do. But you know, we sutured sensors into the graft in the strategic locations, and that allows you to know where the graft is. Now, to know the anatomy, I pre-catheterized the renal artery just to make sure that the renal artery was really where the system was telling me it was. And you can see the bifurcated device is advanced. And once we deploy it, dislodge that catheter away. And now we adjust the parallax. And this was the gate catheterization, which nowadays with a new software, you'll see in a minute, is much easier. So I want to confirm that with IVUS to make sure we didn't do a chimney on that iliac artery. And now the iliac limb is introduced, and we deploy. Even the balloon was actually sensorized. And then we did the CT at the end to prove the concept. And you can see how close we were from the target, which was the left renal artery on this case. We were like a millimeter close to the target. And that was without any fluoroscopy whatsoever. So this is very much possible to do, and very much possible that in the future, you know, we have this available. Now, there is a software with this. Now you can actually see the stent, and this is, we've been doing this experimentally with the medical students and the residents to catheterize the gate without fluoroscopy. And in fact, they have augmented reality. So you can use a Google lens and take the aorta out of the patient and put it in a comfortable position so that you can catheterize the vessels. And interestingly, we checked the time for catheterization randomly in this cohort. And for people that are endovascular naive, they've never touched a catheter before, you can see that augmented reality is associated with the fastest rate of improvement as compared to flat screen or fluoroscopy. So that's very encouraging. And in fact, even for the expert surgeons, the fastest rate of catheterization was augmented reality. I like to say it's like you walk in a room and you just walk to the table or you walk to the door and you're like you're walking inside the aorta. It's very impressive. Now, we've been doing experiments also with advanced techniques, and you can see here we can delete the stent and keep only the branches there of a T branch. And we've been using this clinically to avoid lateral views on catheterization of fenestrations. And you know, you can see the wire and the catheter going into silic and SMA. I think as the technology improves, this has a great potential. This is now an experiment to catheterize a branch and the target vessel using augmented reality here. And you can see as you point to the vessel, it becomes green, and you just shoot the wire inside. And this is an SMA. The ergonomics are totally different with augmented reality. As I said, you move your head, and you can actually look at the stent in a complete different perspective. So that's really fascinating. So open surgery and stent surgery have very important roles on these patients. I like this acronym of FRAGILE. We look at frailty, clinical risk, anatomy, genetics, life expectancy. There are 3 options here: open surgery, endovascular, no treatment. And I would say endovascular is moving in most centers to become the standard of care for patients that have the anatomy suitable and that do not have genetic disease, but also in selected patients with genetic disease. So in conclusion, branch thoracic repair is associated with lower morbidity and mortality compared to open surgery, despite being used in older and high-risk patients. And the overall rate of secondary interventions after open repair is not low, and in fact is higher than fenestrate repair. And the limitations are access, cost, and secondary interventions. Thank you very much, guys.